firstly, the National Institute of Malaria Research is responsible for research into many aspects of malaria, including implementation research and operational research, which then the national program actually is responsible for running the show in terms of malaria control and in this case, malaria elimination. So to be fair, the interview should have been, the interview should have been Dr. Neeraj Dhingra, who's been very ably running the national program over the past many years, overseeing 6 eliminable diseases, including malaria. As you know, in India, there has been a very drastic drop in malaria incidence from, say, 2015 onwards. However, malaria in India is very heterogeneous because the geography in India is very varied. It's a very big country, as you know, of more than 1.3 billion people. And there is a huge variation in all kinds of issues that impact malaria. For example, urban versus rural, in terms of healthcare facilities, in terms of host factors, in terms of parasite resistance to specific drugs, in terms of vector resistance or susceptibility to various insecticides. So literally the 35 or 36 odd states and union territories of India, not all of them have malaria as endemic, but it is estimated that close to 80 to 90% of India is at risk of malaria. Now, when we say risk, of course, that implies that there are suitable conditions available for transmission. However, that may not be actively happening as of immediately today in some of or many of the states. There are, of course, there are about 7 to 10 states where the problem is really highly endemic in the sense of it's a perennial problem. And those are the states which are being focused on now. One of them used to be Odisha. Of course, Odisha has brought down the incidence of malaria significantly. There are other states as well in India where it continues to be a threat. Now, there are many ways to answer some of the questions you may be asking or wondering about in terms of malaria elimination, but please bear in mind for the purposes of this interview that we will not be discussing necessarily the unexpected events in context of malaria in 2020 because of, as you know, COVID disrupted the ongoing, significantly disrupted in many cases the ongoing activities, and therefore it will not be fair to bring up data from 2020. But however, for the purposes, we will sort of we'll be focusing on data till 2019, which looked good in terms of on track for malaria elimination on the whole, but not quite, as I will explain later. First of all, the target is actually 2027. And then another 3 years to ensure that there is zero transmission is maintained. So a target is much sooner than we suspected. Let's say it's within 5 years or so. Now, the strategies that the national program has adopted, and I'm not, again, I'm speaking on their behalf, is that they have broken down the problem into a sub-national problem. They are going state-wise. And one of the approaches that they've taken is to basically look at distributing state-wise, stratifying the malaria incidence data in terms of 3 or 4 categories, the 3 categories. And those are in those states that are in pre-elimination phase, elimination phase, and intensified surveillance phase, etc., where API is high, have been categorized, and sort of tailor-made strategies should be adopted in these states. But if you look at the situation, for example, Punjab, for example, on our western border has very low levels of malaria, whereas when you go to the eastern parts of India, for example, specifically the northeast, but of course the central India states of Madhya Pradesh, Odisha, Jharkhand, and others have quite significant load of malaria still. So one of the activities that we have started at NIMR recently has been to track, India is broken into some 740 odd districts. Now, district is the administrative level for malaria control de facto. So, malaria data is presented in terms of API, the annual parasite incidence. In terms of each district has an API. Now, whether that's fair or not has to be, we can discuss another time, because API, as you know, is dependent on ABER, which is the, there's a very clear correlation between slight positivity rate and API in terms of ABER has to be close to 10%. That is to say 10% of the population's blood slide should be checked for fever and followed on. Now, where ABER is not 10% and is significantly lower, the APIs will tend to be unreliable. Where ABER is higher than 10%, of course, they will be reliable, but somewhat more reliable. So API as a way to categorize states, maybe perhaps we are wondering maybe whether that should be looked into again. But for example, if you look at, say, if you ask the question in 2019, what were the states, or in other, if you want to look at more granular data, what are the districts where the incidence of malaria plateaued, as in it's not dipping anymore? Okay, there is obviously districts where it's just a straight line is going through wherever, it's dipping over 5 years. You can make a projection that in another 2 years it'll be very low, or it'll be zero incidence possibly, except for migratory malaria. But where it has leveled off, and WHO has made this observation for countries outside of India as well, where it is leveling off is a matter of concern. For example, whether you want to call it persistent malaria or recalcitrant malaria or residual malaria, the fact is that after, say, from 2015, 16 to 17, 18, it's sort of plateaued and it's not going down significantly anymore. And in some cases, in fact, on the rise. Those are cases for worry. So now we have made an analysis of, it's not published as yet, but there are sort of 30 odd districts where this is happening. Now that's quite alarming because these 30 odd districts have significant amount of malaria already. And the rate of decline of malaria is not appreciable, let's say. So the questions then this poses to everybody are, why is that the case? Is the environment far more suitable? Have the vector behaviors changed? Has the vector susceptibility dropped? Has the parasite resistance come up more? Are they really hard to reach in inaccessible areas? And the answers, I should tell you, will be, we don't have the full report as yet, but the answers will be a mix of all of these issues. Some areas will have all the problems in one area, and some areas may only have one or two problems. Now, that necessitates that the program, for example, then move forward in a tailored approach. One size fits all will not work for all the districts when you're talking about residual or so-called persistent malaria. And so those are, we are bringing out this document in, and we will discuss with the program and perhaps make some recommendations. But I suspect that going forward, we will have to take a much more, district by district approach for the high malarious districts rather than a blanket approach. This approach was interesting. I think the state government was very, very keen to, first and foremost, you had tremendous political commitment, which is really required in such a large country, state commitment. But, from my understanding and looking at the review of literature in regards to CCMP, the approaches they took were very self-evident and somewhat, intuitive. For example, mass screening with RDTs was implemented. And if anybody was found to be positive by RDT, regardless of symptoms, so for example, now you have to pay attention to the fact that the asymptomatics or people with, asymptomatics or people with, sort of very low-grade fever, etc., were still treated. So you were clearing out reservoirs of infection. So basically mass screening. Now mass screening itself, of course, it's a tool that's been around for a long time, but there are costs involved with mass screening and treatment. To take care of the mass screening and drugging for all positive patients. And that really sort of helped because the outreach of the programs increased drastically when local people were involved in let's say, distributing healthcare. They were doing surveillance as well as healthcare to a certain extent. The third part was that they, as far as I understand, the state government made a tremendous effort to go to inaccessible areas. There are parts of India, many parts of India, one would say, which are essentially inaccessible to modern healthcare, let us say, because of geographical reasons or there may be other political or a combination of all kinds of reasons, for example, insurgencies, etc., which makes it very difficult for a lay person or lay scientist or a lay program worker to just easily approach these regions, even if you are there to dispense healthcare, but you are looked upon suspiciously, for example. So, but there could be, of course, clearly geographical reasons which make these places inaccessible. Then, of course, implementation of LLINs obviously tremendously helps. We know LLIN has been a game changer for malaria in India and elsewhere as well. And I think periodic training of the staff who either it is for surveillance training, for RDTs, for drugging, etc., case follow-ups. I think that periodic training also sort of paid off. So some of the features that were implemented in Odisha are not rocket science. They are highly implementable if they were to be done to fulfillment. Problem with malaria control to a certain extent is that we have 3 or 4 tools, but each of those tools, if you implement 70, 80% or 20, 30% or some variance of that, much less than 90%, then the sum effect is far lower than the same 4 tools, which are far from rocket science. If they were all implemented at 90%, you would see a greater effect. So it's I think in this particular case, that is my assessment of the situation. Now, whether it's that's scalable or not, of course, you don't need to scale it for all the states in India, because not all states in India have this kind of malaria burden that Odisha did. I would argue that some of the lessons learned from that should be directed at a district-wise level. As I've discussed with you, we've made a list of these 30-odd districts which are, let's say, persistently having malaria and no reduction anymore, or very little reduction anymore. Of course, there are new foci of malaria that have come up in 2019 because of local epidemics, etc., for unknown reason as yet. So there are new foci coming up, and it's very likely that there would be new foci in 2021 when surveillance will be back up. I'm not even sure it will be back up this year, given what's happening with COVID at the present moment. But nonetheless, let's say that happens. So I think that kind of model would be, it's not a question of scaling it up. It would be sort of taking the best learnings from it and implementing it in a district-wise fashion at these sort of recalcitrant districts when we talk about malaria incidents. I think that would be, in my assessment, something of utility that will come out with that. Now, other countries, of course, can learn and do this either state-wise or region-wise, what was learned from CCMB. But as I said, it's already there. Everybody knew this. These are the tools that should be used. The research environment has changed significantly in the sense that, because of this goal, this projected goal of malaria elimination, let's say within 5 to 7 years or 5 to 10 years, as you like, the research community has become sensitive that this sort of open-ended blue sky research, although that's still very good, but there are now being questions asked, what will we have within the next 3 to 5 years? Now, for example, our lab has been involved in discovery of, let's say, new inhibitors, which are, quite potent against the malaria parasite. But and there are people interested in vaccine development and so on. And we all have to be aware that these new tools should be available within the next 5 to 7 years for it to make an impact in this phase of malaria elimination. Correct. So on the other hand, the research community, has grown significantly. From when I started in malaria, some almost 2 decades ago. I think probably a log order more scientists are there in terms of labs. They're very well funded. And there's a lot of basic science, which is really of high quality, which is going on. And I'm very pleased about that. But I think, as I said, there is a sense in the community that they need to show outcomes. They need to show something translatable. They need to contribute somehow to elimination, let's say with coming up with new diagnostic tools. Now, even if it's not new diagnostic tools, let's say it's the same old diagnostic tool of microscopy. Microscopy is tedious and painful, and it should be, I think it should have been robotized a long time ago. And there are now, that's happening. There are groups in India that are interested in doing it. There are international groups that are interested in digitizing this. And I think that is the way of the future. That is something that must be incorporated in the program when you talk about elimination. You can move forward from that. You can say, for example, how about G6pd testing, because of course, as you know, radical cure can't be given for people who are deficient in G6pd. We are still working with primaquine, but tafenoquine has not been launched in India, a single dose radical cure, which again is partly because of the fact that the G6pd testing isn't widely available. Now, the question is, after COVID, I think after COVID, things have changed so significantly that these small excuses are not, tenable anymore. You can't say that I can't do RT-PCR on malaria patients to check the parasitemia, whether it's low subpatent parasitemia, because you're doing it for millions of people for COVID now anyway. So I think in that sense, the infrastructure development in context of diagnostics has sort of blown up so much across India that, and we have written a few articles on this thing. And I think if heads were to be placed in the correct position, then it's possible to leverage that infrastructure partly for malaria and partly for other infectious diseases as well, in terms of diagnostics. As you know, surveillance is the key issue. Improve. It's not necessarily that we need a new RDT kit per se. It would be just that perhaps can PCR routinely take over, or something much more point of care based, like LAMP technology, etc., could take over, for example. Or you could have still a digitized version of microscopy that is possible, and you could link it with AI systems and so on, so that at the point where the drop is collected, from there, the digitalization and visualization happens at a centralized server. I think those are visionary things, and those are possible now. And I am very sort of pleased with the fact that we have made a lot of calls from malaria for these kind of ideas via Malaria Elimination Research Agenda Alliance. It's called MERA, MERA. It was launched by ICMR like a couple of years ago, and we funded huge number of studies across the whole of India. These are 2-year projects where the question should be answerable, and it should be of utility for elimination within a span of 2 years. For example, you want to check something on insecticide resistance, you want to make maps, you want to come up with a new tool or you want to assess the low burden, low density infection prevalence in a district, for example, so that you have a clearer picture of the overall burden of malaria. So these are 2-year projects, and the funding has already started. So some of the ideas I mentioned in terms of AI, microscopy, new tools for PCR-based tools for diagnosis are actually being now used or deployed via MERA India funding, which is from ICMR in any case. So I think in that sense, there is a lot more alignment between research and control. And there is a bit of additional sort of accountability on part of the researchers to do something for elimination agenda. Well, I should be taking message from young people, I tell you frankly, rather than me giving messages to young people. But I give these talks sometimes, and one of my last slides is that one of my last slides says, if you're bored of malaria, then you're bored of science. So I think malaria still is fascinating, and it will probably remain fascinating, notwithstanding our progress towards elimination. As you know, I come from a basic research perspective, and there is just a lot to be discovered there. And I think for young people, they are not only young people, all people, including myself and people who are at the end of their careers, this is a great time to be involved in research, because we have information, all the way from genomics and atomic level information from protein structures and genomic information spanning all the way till epidemiological information. What we've been significantly missing, but that we are covering up in leaps and bounds, is the same information on vectors. Vector genomics is now commonplace, and of course the host genomics. I think the host factors are still significantly understudied for my taste, and I think that's where perhaps the young generation can focus a lot more. What are the reasons why in a small fraction of people malaria progresses towards severity and others it doesn't? I mean, that's a sort of a similar question in COVID, let's say. So, and although you can do hand waving that there's comorbidities, etc., but that doesn't still clearly, at a molecular level, define why that is happening. And so I think for young people, old people like me and everybody else, I think host factors remains a relatively less explored area where perhaps a lot more attention can be paid. Yeah.